that the patient is imposing on the respiratory system. And when we consider a patient who is spontaneously breathing, I think that what is inspiratory pressure, it's important that we keep in mind, as we are probably aware of, that the inspiratory pressure is not just the pressure we see on the ventilator screen. So here you have the same patient in two very different conditions. This is pressure support ventilation. You have two very different peak inspiratory pressure, 20 and 10 centimeters of water. And if this was pressure controlled ventilation, I think we would be very much convinced of the fact that this condition here on your right hand side is less injurious for the lungs than the condition on the right hand side. Just because the pressure that we have to deal with is the pressure that we see on the ventilator screen. However, things become a little bit more complex, or actually fairly more complex, when we deal with spontaneous breathing. And this is because sometimes our pressure, the pressure that are applied on the respiratory system, are hidden. It is like as if we had an iceberg, if the total pressure that is applied on the respiratory system is an iceberg. And exactly like an iceberg, it can be very dangerous because we only see part of the pressure in our ventilator, and the part that we do not see may be and often is much larger than the one we do see. And so out of the iceberg metaphor, we have the pressure that we see on the ventilator screen as the inspiratory pressure delivered by the ventilator, but we have a large, we may have a large amount of pressure which the patient is generating that will add up to the pressure generated by the ventilator, which we do not see, but which can be as dangerous as the pressure that we see on the airway. So, whenever we shift the patient from, let's say, a condition of fully controlled ventilation down to a level of high, medium, and low support, we will see that peak airway pressure, mean airway pressure will be decreasing. And once again, this does not mean that the injury for the lung is decreasing, that the risk of injury for the lung is decreasing. Indeed, if we look at the transpulmonary pressure, the pressure that the lung has to support, this will be exactly the same no matter the level, no matter the level of assistance that we are delivering, because the patient is putting into the system the pressure that we are taking away from the ventilator. So, going back to our metaphor, the size of the iceberg is the same. We are just flooding a larger and a larger part of the iceberg. So we would like to know what is the total pressure applied to the respiratory system. We would like to know the size of the entire iceberg. How do we do that? Either we have a sonar or we dive under the water, so we have an esophageal pressure catheter, and this is more and more used, more and more common, but still I think it's a relatively sparse use, but I think it's an excellent way to track the entire pressure applied to the respiratory system. Or we let the iceberg out of the water where we see it. We let the entire pressure in the airways where we can see it. How is this doable? We have been using this technique actually in our ICU for several years. There was a publication by Giuseppe Foddi about 20 years ago on this, and then now we reappraised the potential clinical relevance of this. So this is again your iceberg. It's a little bit more square, but the concept is the same. This is pressure support ventilation, which is, I would say, one of the most commonly used assist ventilatory modes, but this would work also, for example, in pressure assist control in exactly the same way. You have the ventilator pushing on one side, and you have the patient pulling from the inside, and you have a negative muscle pressure applied to the system. At the end of inspiration, the patient ceases her or his effort and just relaxes the muscles to be ready to the passive exhalation to follow. And at this stage, this pressure that the patient was generating returns in the system. And if the expiratory valve was open, this pressure would lead to exhalation. But as the expiratory valve is closed, because we are pushing the inspiratory hold button, the pressure cannot leave the system and stays in there, and we see it as a plateau. The fact that this plateau is flat highlights relaxation of the patient. We are still working a little bit on this, but a flat plateau normally indicates a patient relaxation. And this plateau pressure has exactly the same meaning of the plateau pressure that you do measure during controlled ventilation. It depends on the tidal volume and the compliance. It's the entire pressure that is applied to the respiratory system. So if we go back to our patient who I've shown you before, we have a peak inspiratory pressure of 20 here, 10 centimeters of water here. If we push our inspiratory hold button, you will see that the plateau pressure which we see is exactly the same, because it's the same patient, more or less the same tidal volume. The total pressure applied to the respiratory system is the same, except that here almost all the pressure was being done by the ventilator, and here the patient is putting a lot of pressure into the system. And yes, your plateau pressure in this situation can be higher than peak inspiratory pressure. Is this just an idea? We believe it is a little bit more than that. We have published a few years ago a validation study in which this is reanalysis of another study, but anyway, the patient were switched at some point from passive control mechanical ventilation to pressure support ventilation. And as you can see, if tidal volume is kept constant, the plateau pressure which you measure during the two conditions is very, very similar, close to the line of identity. The nice thing about this is that I would strongly recommend you to go home Monday morning and do this. You do not need any additional equipment, you just need a ventilator which allows to do an inspiratory hold during pressure support ventilation, which unfortunately not all the ventilators do. And we published this short movie on ICM to see how this works. You see, you just push the inspiratory hold button and you get your plateau, which at times, not in this case but in the previous one, is higher than peak. And this concept of plateau pressure being higher than peak inspiratory pressure is not just a strange Italian job, but was recently, I was very much pleased to see this recent report from Dr. Sayad, who basically found out the same situation in which plateau pressure is higher than peak inspiratory pressure, and he clearly makes the point in the nice discussion of this image that this driving pressure has exactly the very same meaning of the driving pressure that we measure during controlled ventilation. And now, of course, Marcelo has told us the importance of this parameter, and in his paper one of the statements says that this is valid only for ventilation in which the patient is not making any effort. And so our hypothesis is that indeed, if we measure driving pressure the way I've shown you, also during assisted ventilation, it will have the same value as during controlled ventilation, and so it must have the same relationship with outcome that driving pressure does have during controlled ventilation. So we set out a retrospective observational study. We could do it single center because it's not really a common measure, but in our SU, doctors are used to that and they just write down the values in the chart every day. We screened all patients that after controlled ventilation were switched to assisted ventilation. It's not necessarily a weaning phase, it's just after the very acute phase, the onset of spontaneous activity, like we heard from Laurent, who had an ARDS and some exclusion criteria that are quite standard, I would say. This is the population. Out of almost 2,000 patients that had been admitted, we found over a almost 4 years period about 160 that could fit. For some of them, the plateau pressure was not charted in the medical records, but for 154 patients, we were able to find and analyze these values. As I said, we have a population that is being switched from controlled to assisted mechanical ventilation. So we have, let's say, a last measurement in controlled ventilation, and then typically the day after we have a measurement in assisted ventilation. And here we rely on compliance because the value should be more or less the same irrespective of tidal volume. And we found, I would say, a decent correlation. The two values are not identical, but of course, after 1 day the patient can have changed a bit, and of course these patients were switched to assisted ventilation. So I'm not surprised to see such a scatter. And to further validate the concept of compliance and plateau pressure during assisted ventilation, we took those patients that had undergone a CT scan in their period of assisted ventilation. We measured the size of the baby lung, which during controlled ventilation is known to correlate with compliance, and we found a significant, statistically significant correlation with compliance measured with this technique during assisted ventilation. How about outcome? We have 120 patients that survived and 34 patients who did not survive. The mortality is rather low because, remember, these are patients who had already passed the very acute phase in controlled ventilation. This paper is under review right now. If anybody in the room is reviewing the paper, I'd be happy to buy you a beer. And so if we compare the survivors and non-survivors, you see that the peak inspiratory pressure that we see on the ventilator screen is not really different. But of course, the driving pressure is significantly higher in patients who do not survive, and the compliance of the respiratory system is significantly lower. So there is an association between higher driving pressure, lower compliance measured during assisted ventilation, and mortality, reinforcing, I believe, the clinical value of this measurement. And as we know, driving pressure goes along very well with quartiles and quintiles, so we also compare patients in different quintiles of various pressures. If you compare quartiles of peak pressure, here you have patients with increasing quartiles of peak pressure. You see no increasing outcome with peak pressure, exactly for the reason which I've shown you. The peak pressure doesn't take into account the pressure that the patient is putting into the system. However, if we look at the association with driving pressure and with compliance, there is a compelling increase in mortality with increasing driving pressure and decreasing lung compliance. And both these are independently associated with patient outcome. So going to my conclusion, I think that, well, this is more a premise than a conclusion. We need careful monitoring of our patient when spontaneously breathing. And I think that plateau pressure can accurately be measured during PSV, and the fact that it's higher than peak is not an artifact, it's the pressure that the patient was putting into the system. These are both strongly associated with outcome. We would now look for a prospective multi-center validation of these parameters, but we think that this could become an interesting target for protective assisted mechanical ventilation. Thank you so much for your attention.